Welcome everybody. Today's webinar is on the importance of bone health in early breast cancer and impact of bisphosphonates, highlighting importance of genomic analysis, calling for larger studies.
So just we have done 6 months retrospective study for DEXA scan and how it has impact on the breast cancer outcome. So it's a like background little bit. I will give you 1 or 2 minutes and then aims and materials and results and conclusion. So as you know, the aromatase inhibitors have become a standard of care for postmenopausal women and early breast cancer, and bone mineral density does decrease over time. So for Fresco WHO, it does not take into account of aromatase inhibitor use. So we can assess it, but it doesn't take it. So the bone loss actually goes very fast after menopause, especially with the ovarian suppression. If you see, this is the very famous slide. The AI is just a 1% or 2% loss with AI, but when you remove the ovaries or with the ovarian suppression, it's an exponential loss. So a huge loss. So this was the first study which has shown that zoledronic acid or bisphosphonate does help. But if you see here, this was based on the soft and text study. It has no survival benefit, the ovarian suppression, but it does have disease-free survival. And we are more worried about distance-free survival. The advantage of ovarian suppression is only 2% for distant-free survival. So if you go historically to 2011, this was the first study which has shown that zoledronic acid does improve bone mineral density. And this was the result at that time. I will just skip that very quickly. But later on, Australian study in 2012 has shown that overall there was no benefit of zoledronic acid. This was a randomized trial. It was a negative study on overall, but it has shown benefit in postmenopausal women in a sub-analysis, you can see. But we have in UK Azure study, which was also randomized trial for zoledronic acid for 5 years and control arm. We were part of it. Cancer Center, Northstar was part of it. It was negative study, which is both after 10 years, there was no benefit of zoledronic acid in women. But there was a sub-analysis that had shown some benefit in those patients who had established postmenopausal status at the time of randomization, like 55 years or above. There was another sub-analysis which has shown that patients who are MAF positive, this was a gene which was positive in 30% of patients, they do worse. So the survival outcome was worse in those patients who have MAF positive genes. So obviously this was a prognostic, whether it is a predictive or no, we have to see. The further meta-analysis, because this was a conflicting result from Austria is coming positive and in UK coming in negative. Then a meta-analysis Oxford group has done. This meta-analysis was the biggest which has done the nail in the coffin, and it has established that zoledronic acid or any bisphosphonate actually has a 3% survival benefit, 10 years study, 26,000 patient meta-analysis it was. So after that, quickly, very quickly, all the guidelines came up actually from all over the Europe and North America. We follow these guidelines. So first of all, just check whether patient is postmenopausal or no. If postmenopausal, then consider bisphosphonate. If not, then see whether patient is becoming postmenopausal after the treatment or ovarian suppression, and then select patient for oral or IV. There is no difference between any preparation. So NICE has quickly launched um, in 2018 guidelines. It has shown offer bisphosphonates only for those patients who have postmenopausal status and with node positive patients. and consider bisphosphonate to those patients who are node negative. Obviously, you can consider it, but actually they do not recommend it as such. And also they have suggested to do regular bone density scan. So offer only bone density scan to those patients who are not receiving bisphosphonates. So if you have already started bisphosphonate to some patients, so NICE doesn't recommend to do bone density scan. And same is the case for those patients who are on tamoxifen. The aim of our study was to see aromatase inhibitor for breast cancer patients, short-term outcome on bone health and monitoring and management of bone health, looking at compliance to current guidance. So it was registered in our staff this audit. It was 2015, 6 months. We have collected all the retrospective data and just checked all the DEXA scan findings and when it was done. So we have calculated short-term effect of AI and monitoring and management of bone health in early breast cancer patients, looking at compliance, because this comes into the GP, but sometimes patients are at loss. They are just stuck between oncologists, endocrinologists, and sometimes nurses, and somewhere in the GP area. So we have gone through these 289 patients. If you see here, they are uh, majority of them were ER positive, as you know. 80% was ER positive, small number were triple negative, and around 10 to 15% were two positive. So this was our 75% had bone mineral density scan in the first place. Age Average age was 76. So serial bone density measurement were done in those patients. But if you have seen 140 patients with bone density with AI, and all of them have bone density scan, the second scan was done only in a small number of patients. So I will just move the next slide. So this is the all DEXA scan patients and endocrine treatment. So some of the tamoxifen patients were also having DEXA scans. And this is a percentage of patients on AI who had DEXA scan, the first scan and then the second scan. If you see 70% patient who were on AI had DEXA scan, and then around about 40% patient on the second scan after 2 years. Now, this was the breast cancer treatment. Majority of them had this chemotherapy and some of the radiotherapy and all those treatments. Main thing was the risk factors. Patients were having significant risk factors, for example, rheumatoid arthritis, diabetes mellitus, previous history of fractures, or family history of osteoporosis, all these things, or smoking actually, ex-smoking even were and also ovarian suppression in some patients. Now, this was the DEXA scan result. So if you see, majority of patients were in the range of osteopenia, and among them, 21% were in the range of osteoporosis with T-score reading lower than uh, minus 2.5, and it was 40% were having reading between -1 to -2, showing osteopenia, which was 20% of them found to have T-score reading was abnormal. So at the start, a lot of patients, 50% of them were actually having low bone density at the start. We also actually done correlation between uh, with the curve. So there was a direct correlation between the age, the between the bone density and the age was a worst factor, and comorbidities as well. Majority of the comorbidities we have taken the same as FAREX score is taking. WHO FAREX score has counted rheumatoid arthritis and diabetes mellitus, previous history of fractures. And this was the correlation between first DEXA and the second DEXA. Obviously, when the second DEXA time, the bone density was worse. And we have only treated around 40% of patients with bisphosphonates. And there was no correlation between the progression-free survival with osteoporosis or use of treatment. So the conclusion is in our study, 55% patients were having either osteopenia or osteoporosis at the start of the treatment. Almost 15% patients were detected to have osteoporosis at the start. They were started on bisphosphonate along with AI. Therefore, we recommend that all patients undergoing breast cancer treatment should have DEXA scan at the start and during the treatment to screen those in need of treatment with bisphosphonates. And this is the impact statement that monitoring and managing of bone health in all breast cancer patients is imperative. In fact, larger studies are needed to focus on genomic biomarkers to select those patients who benefit from adjuvant bone modifying. If you get one point from out of my talk is this one, that there are small number of patients, around 30% patient, where MAF gene is positive, and we can do harm by just prescribing them more these bone modifying agents, because it can send the niche somewhere else from the bone, and the survival has shown that it has reduced in Azure study. So that ends my talk today. I think if you have any questions, these are my references. And
Okay, good presentation, good work actually, Shahid. When you take a patient out of the community, if you compare this data to a community patient who has been diagnosed as osteoporosis, the bone density improvement over the course of time, does it actually exactly mirror what you're seeing with patients with AI as well? Or has AI has got a massive impact in terms of the improvement that the bisphosphonates actually can cause? So is there a difference? What I'm asking is, giving bisphosphonates to a patient on an AI, is it different from a patient not on an AI who's got osteoporosis as well in terms of the BMD? I don't know. That's why I'm asking you the question.
yes, there is a difference. That MAF gene is the one which is your study has shown. So there are small number of patients, which is 30%, where bisphosphonates has a worse outcome in those patients if we give them, because there must be some change in the microenvironment, or they push the cancer out and into somewhere else and they die quickly. So is your study is the UK, one of the biggest study with 3,000 women. We have been part of it actually, and they looked at this biomarker. If this biomarker is positive, then obviously they do worse in terms of progression-free survival and overall survival. It has prognostic value, but predictive value, we don't know yet. It is a kind of a thought, food for thought, whether we have to look holistically when prescribing bisphosphonate for our patient. But meta-analysis has shown 3% survival, which is, basically the ESMO has given the guidelines. Check the postmenopausal status. If patient is above 55, prescribe it in node positive. Node positive and high risk patients, NICE also is recommending that.
Thank you everyone for attending Bone Health in Early Breast Cancer webinar today. Hope you have enjoyed it. Have a nice day.